The Genuine Article. Discussion and commentary based on articles from JACC.
Hello, I'm Tony DeMaria, the editor of JACC, here with another issue of Inside JACC, and I'm talking to Dr. Edward Hulten, who's on the staff of Walter Reed Hospital and who's completed a very nice study about to be published in JACC that deals with the prognostic significance of coronary computed tomography angiography or CTA. And although there's a lot of information about the diagnostic value, there's been less information about prognostic value, primarily because the studies have been relatively small. And so what Dr. Hulten and colleagues did was a meta-analysis. They managed to identify 19 studies, including over 9,500 patients. And as they looked at these studies, they analyzed them for the evidence of major adverse cardiac events or death. And in fact, what they found was that if a patient had any obstructive coronary disease at all, more than 50% in even one vessel, that the annualized rate was just under 9% for events or death. And if they had a negative test, it was under 2%. The rates for death as an absolute were twice as great if you had some coronary obstruction on the CTA. So evidence of rather significant prognostic power. So let me ask you, Dr. Hulten, you dealt primarily with patients who were symptomatic. How would this apply to patients who were asymptomatic?
Thank you for having me. That's an excellent question. These studies were all in patients being evaluated for symptomatic angina. And there are a couple of studies of asymptomatic patients, but the evidence is still growing. And so at this time, it's being used in research studies of asymptomatic populations, but there is no widespread recommendation or appropriate use statement that says that CTA should be used in asymptomatic populations. The problem is that you find a large burden of subclinical atherosclerosis, but very few of the asymptomatic patients have, in fact, obstructive disease. And so the population is probably overscreened.
So now one of the issues that always comes up is that revascularization is an endpoint. And so just the finding of an obstructive lesion may lead to the so-called oculostenotic reflex. What did your data show if you eliminated revascularization as an endpoint?
That's an excellent point. There is a self-fulfilling prophecy after a diagnostic test that patients who are found to be abnormal will be revascularized. However, heart events in terms of death and MI still occurred at significantly increased rates in the patients with obstructive disease, 2% per year for death and MI. And so even in the absolute events of heart outcomes, there was a significant difference.
So how does the prognostic significance of CTA compare with, say, stress echo or stress radionuclide techniques?
That's another excellent question, and that was one of the primary motivations that we carried out this study. There are a handful of studies that provide comparative clinical outcomes, but there was insufficient data in this meta-analysis to compare amongst modalities. However, what is reported are the summary statistics for stress echo and nuclear stress testing. And in fact, cardiac CT, in terms of prognostic value, is comparable to those tests. But I think it's an area, it's an area that warrants further study.
So last question, the data are pretty strong. If you have a negative test, your prognosis is excellent. What do you do with the patient who has a positive test?
I think that's a gray area in terms of patients that have mild disease or worse stenosis less than 50%. Certainly most practitioners are aggressively medically managing them, but there's a lack of outcomes data for the management of subclinical atherosclerosis that's detected on imaging studies at this time.
So our information about coronary CTA continues to increase. We need data like this to properly place this powerful tool in our diagnostic armamentarium. For Inside JACC, I'm Tony DeMaria.